Hello, everybody.
Hey.
Welcome to the Research Roundtable, the IOCDF live stream where we pick an interesting topic within the OCD literature and discuss it with folks who know it very, very well. My name is Kyle King. I'm a first-year medical student at the Yale School of Medicine. I'm an international OCD advocate or IOCDF advocate, and I, more importantly than those two things, am someone who struggled with OCD. I was diagnosed when I was 13. I've lived with the disorder since then. And because of that, a lot of the things that we talk about on the stream Hakers, a lot of things that we talk about on this show are very relevant to me. And I really love hearing about them. As always, I'm joined by my co-host, John Abramowitz. John, if you'd like to say a word or two about yourself.
Hey, sure. Thanks, Kyle. It's great to be here. I'm John Abramowitz. I'm a professor in the psychology department at the University of North Carolina. I study OCD, understanding how it works, its treatment, all things OCD. And this is one of my highlights of the month, is being here with Kyle and our distinguished guests. So I'm looking forward to today's live stream.
Yeah. I'm looking forward to it too. As you can see, I scribbled things on the whiteboard behind me to appear intelligent. So I'm really locked in and ready for this stream. And today we're going to be discussing OCD and inflammation and the connection between the two, which for people who watch the stream regularly know, they probably know excites me a lot because I like to approach this disorder from a more biological perspective at times. And I expect John to come at it from a different perspective throughout the stream, which I'm excited for. We also have two great guests on the stream with us. Three. There we go. We have the full panel just in the nick of time. Hey, Jenny.
Hello.
We have three great guests on our panel today, and I will be introducing them shortly. But before I do so, I have some announcements that I must go through. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF online resource directory at iocdf.org/find help to locate a trained clinician near you. Second, the International OCD Foundation is not a crisis hotline. If you're in crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org or go to your local emergency room or call 911. Also, I share this at the beginning of every stream. Just know that everything. This is a live stream. There's a comment section. If you put anything in that comment section, we do read it, and we love when you guys put comments in there and you ask questions, and we try to get to as many questions as we can throughout. But because this is a live stream and because it's on the internet, whatever you put in there will last on the internet forever. So just be mindful. Although we've never had any problems. Also, just kind of a plug. If you want to support the awesome research that the IOCDF supports, including research on inflammation and OCD, go ahead and visit iocdf.org/donate-research. Forever ever ask Cash in the comment section. I don't know if this stream will last on the internet forever ever, but go ahead and visit that website and consider donating to OCD research like we're going to discuss today. It's super impactful for the community. I know as someone with OCD, I appreciate any support a lot. Okay, I've spoken a lot. Time to turn our attention to our guests. The first guest that I'm going to introduce is Donatella Marazziti. Dr. Marazziti is a professor of psychiatry and applied psychophysiology at the Departamento de Medicina Clínica y Experimentale, which I was told is a good pronunciation.
Well done.
Congratulations.
So she's a professor of psychiatry and applied psychophysiology in the section of psychiatry at the University of Pisa and a professor of clinical psychology at the St. Carmelis University of Health Sciences, Rome, Italy. She's a member of several international and national scientific societies and communities, the co-editor-in-chief of CNS Spectrum's funding editor of clinical neuropsychiatry, a member of the editorial board of the World Journal of Biological Psychiatry, Life and Annals of Psychiatry. Her research interests are focused on biological markers in psychiatric and normal conditions, emotions, attachment, psychopharmacology, and clinical psychiatry. She has authored more than 650 papers, mainly in international journals, 9 books, 2 essays, and 1 novel. Donatella, I normally like to start this stream by asking a silly question to break the ice with the guests. And you mentioned there at the end, you've written a novel. So I wanted to ask, what's one nonfiction novel that you recommend everyone read?
The Elective Affinities from Johann Wolfgang Goethe is my favorite novel.
The Elected Affinities. I've never heard of it.
Yes, it's a classical book on the powerful and detrimental effect of love. And you know, OCD is
goodness.
very similar to love, especially in the early phase. So I think everybody can understand. And you know, the writer that is Goethe was a good writer, an excellent novelist, but also a scientist. He discovered the theory of colors, he described it, and also one small bone in the face. So as it used to be at that time, he was very eclectic. And he wrote in this novel that probably there was the chemistry influencing falling in love and love. So I think he's the first scientist underlying the relationship between biology and emotions. Very important. Right.
Well, I mean, as a college student,
Talent and very it's a wonderful book.
I don't know. As someone who's still working on not eating Pop-Tarts for dinner, I don't know if I'm really ready to tackle a book about the power of love, but one day I'll get there. Our next guest is Dr. Jenny Frankovich. Dr. Frankovich is a clinical professor in the Department of Pediatrics, Division of Allergy, Immunology, Rheumatology at Stanford University, Lucille Packard Children's Hospital. Her clinical expertise is in systemic inflammatory and autoimmune diseases that co-occur with psychiatric symptoms. She completed her training in pediatrics, pediatric rheumatology, and clinical epidemiology at Stanford University. She directs the Stanford Immune Behavioral Health Program, where she and her psychology collaborators have created a longitudinal clinical database and biorepository of patient and healthy control biospecimens. In addition to generating clinical data to better understand immune behavioral health conditions, she is collaborating with basic science labs who aim to understand the immunological underpinnings of post-infectious neuropsychiatric conditions, including PANS and related conditions. Dr. Frankovich, thanks for being with us. Same question goes to you. One piece of nonfiction literature you think everyone should read?
Well, I mean, I'm in a very controversial field, and so to reassure myself, I read a lot of early American history because there was a lot of conflict and controversy. So the book I really enjoyed and recommend is called Team of Rivals. And it's, about the political genius of Abraham Lincoln and how he negotiated some of the early controversies of starting of early American history.
All right. That book sounds cool. And it's intriguing that you said you work in a contentious space, since we might be discussing some of that today.
Yes.
And our final guest is Dr. Chris Pittenger. Chris Pittenger is Elizabeth Mears and House Jameson Professor of Psychiatry, a professor of psychology in the Child Study Center, department chair for translational research in the Department of Psychiatry, and director of the Yale OCD Research Clinic, which is a fancy way to say that he's a professor at the Yale School of Medicine, although he is not in direct control of my grades, so I don't have to watch my words too closely around him. His research and clinical work is focused primarily on OCD and Tourette syndrome and on the brain circuitry and psychological phenomenon associated with them. One major recent focus has been the identification of antibodies that may contribute to the pathophysiology of PANS and PANDAS and delineation of how they affect brain function. Chris, same goes to you. Non or fiction book. Let's go fiction this time.
Fiction or nonfiction?
Fiction.
Sometimes it's hard to tell the difference these days. I will go with East of Eden by John Steinbeck, which I adore and go back to every 10 years or so, because of its combination of sort of sweeping epic narrative and historical grounding and resonance, but also a lot of interesting character stuff and really getting into the psychology of some of the characters, which is kind of cool.
I read that book when I was forced to in high school, and I really disliked it. But maybe I was wrong.
Maybe.
Let me add, it is very important to read the books at different stages of the life, as
Yes.
Christoph said, because they may show you different features and aspects that you didn't get at the first time you read them. It is, thank you, Christoph. I do the same with my favorite ones.
Hopefully I have developed since high school, so maybe hopefully I'll
You are more mature now, correct?
Perhaps.
All right. So thank you all for hanging in there with my silly icebreakers. Let's start talking about inflammation, which is a word that I feel like is thrown around a lot in a lot of different contexts. But as I've kind of learned in the beginning of medical school, every sort of medical term is a lot more complicated than it seems on face. So before we get talking about anything neuropsychiatric, I wanted to ask just generally, like, what is inflammation?
Complex. I don't know, Chris, do you want to try to answer that?
Well, some of the complexities. So when I was in med school, we sort of thought about at baseline, there is no inflammation. And then when bad stuff happens, these cells come in and inflame. And that was a very simple model, though, of course, what the bad cells come in and do is complicated. And I think what we've recognized is that that's not really the way it works. It's not like when everything is good and happy, there's zero inflammation, but rather there's a constant interaction. There's a constant bidirectional dialogue between, in this case, the brain, but the same could be said of any other tissue, and various aspects of the body that we call the inflammatory system or the immune system. And these things are always active, and they're always interacting and passing information and responses to the environment back and forth. And so when we talk about an inflammatory condition or something being inflamed as a bad thing or as a departure from normal, what that means is a loss of healthy homeostasis, a loss of healthy balance in that dialogue, where you've got more of the kinds of activity that's associated with injury or with infection, that category of activity, things have kind of gotten tilted over in that direction to an extent that is harmful. That's so. But I think that the key point I'm trying to make is it's not inflammation is off good on bad, but rather there's a constant back and forth and dialogue, which is very complicated as we dig into the interests. And so it's a question about that balance. Are we in a healthy balance in that dialogue between inflammatory processes and brain or other tissues, or has that balance shifted in a direction where it's causing problems?
Yeah.
And having post-infectious inflammation is normal, right? Like we all fight infections on a daily basis, and we ramp up our immune system, and then our immune system ramps down, and that's a normal process. So as Chris was saying, when it can't ramp down after an infection, that's pathological. But even the impact of inflammation on the brain may actually be normal, physiologic, and have been selected for over many generations, right? Think about all of the epidemics the human condition has survived, right? And some of that survival may have been self-quarantine. So inflammation affecting the brain during and just after an infection may actually be, a normal physiologic state, so long as it can ramp down. And generally we think of post-infectious inflammation as is ramping down, and maybe going back to baseline around 3 to 4 months after an infection. So if you're hit with infection after infection, you may have a little more inflammation than someone living in a village who is not being hit all the time.
I would like to add some evolutionary comments on that, because the main problem derives by the evolving and developed immune system that in the ancient time permitted to human beings to survive when they have to live in a very hostile environment with bacteria, viruses, with no weapon against them. And therefore, the development of immune system permitted that to survive. But there is a dark side. because, you know, some millennia ago, we have to fight against wild animals, a very hostile environment, aggressive humans. At least we have aggressive humans even nowadays. But, you know, we have less occasion and chance to meet the dinosaurs of these wild animals in big cities, in urban environment. The problem was that, according to some theories, the development of the immune system was parallel and was related to a strong relationship with the anxiety, with the alarm system, and this create problems, the link between immune and stress system. And what happens nowadays? We can more or less, we have antibiotics, you have drugs to fight the viruses. We live in very clean and houses, but the immune system is very active. We don't have the great and hostile challenges of the past. And this create, as probably Jenny knows better than I, here we have a tremendous increase of autoimmune disorders. And we have not to be, to wonder if, let's say, OCD is very common in patients with autoimmune disorders, in anxiety disorder, in depressed patients. What do you think, dear friends, about this evolutionary explanation?
Mhm.
No,
What do you think of the evolutionary explanation? And could you briefly describe what autoimmunity is too? Just that's a different concept.
Danny is better.
Yeah, I mean, I do think that our environment has changed for sure, and the balances are different. And although we don't have as much exposure to like bacteria and soil, and we have less of that, but more viruses in
Yes,
cities,
but anyway,
right? So our immune system is definitely, you know, skewing and
it's
changing through time.
yes.
Yeah. In terms of the question about what is autoimmunity, I usually, in terms of being a clinician, I think of diseases in two ways. Is it a disease of overactivation of the innate immune system, or is it a disease of overactive adaptive immune system? But we also know there's tremendous overlap. So you can have immunogenetic predisposition to both. And then also our exposures, you know, through early childhood does, you know, sort of facilitate immune training. So even though you may not be immunogenetically predisposed to innate immune system disorders, you may have, just through lots of early exposures to infections and other immune system activators, have a more heightened innate immune system. And we also know that, and so when we think about autoimmunity specifically, we think about the adaptive immune system, which is T and B cells. And one thing we've also learned is sometimes diseases start off as the innate immune system with, you know, many relapses, and then it evolves into invoking the adaptive immune system, meaning the T and B cells. So it's, so you know, in the old days, we just thought of it as autoimmunity or not. Now there's a whole spectrum of inflammation that may or may not involve autoimmunity.
Okay. So, I mean, I'm seeing from the chat that things have very quickly gotten a little bit confusing. And that's something that I resonate with as well. We have not done immunology yet in medical school. But what I understand is inflammation is not something that's necessarily bad. It can be when your own body, essentially, like own immune system turns on your own body, and the interplay between like your autoimmune functions or something like autoimmune and something that's not autoimmune is kind of complicated. The difference between the adaptive immune system and the innate immune system is somewhat complicated, and there probably is, or maybe at the very least, some sort of evolutionary component to, you know, why we see autoimmune disorders nowadays.
And innate immune disorders, right? Yeah.
Yeah, and innate immune disorders. But I want to hone in on kind of just inflammation currently, not thinking about the evolutionary mechanisms, although they're very interesting. What are the things that mediate inflammation, particularly as it pertains to like psychiatry? Like, what are the key players that we might be talking about when we think about inflammation in OCD?
I mean, there's many different cell types, right? And now we're learning that those cell types can home to the brain. So there's a cellular component. There's also the bullets of the immune system, right? Cytokines. And we know there are cytokine receptors on the brain. And those cytokines don't always get into the brain, but if the blood-brain barrier is loose, and now we know there's channels into the brain, so cytokines can impact the brain. We also know that autoantibodies can impact the function of cells in the brain. And that's with regards to OCD, that's Chris Pittinger's work showing that antibodies to certain neurons within the basal ganglia can be modulated by the antibodies. So different parts of the immune system impact the brain differently. And then there's also resident immune cells of the brain. So they're actually brain cells, but they have an immune function. Okay. So things that are happening in the body can actually influence how those resident immune cells in the brain, how they're activated and also how they're turned off. I don't know, Chris, you could probably explain it more eloquently.
Well, broadly, I mean, Kyle, your question about how can inflammation or immune processes affect the brain? I think very broadly, there are two ways. Sort of a generic or general way and a specific way. So generically, I mean, the brain, in order to function properly and process information and do all the wonderful things it does, it needs to be in a very carefully defined state. It needs to have the right temperature and the right pH and the right amount of salt and all of these things need to be kept in balance. Inflammation, along with a lot of other things, can screw that up, can throw things out of balance, right? And so just having a fever makes you feel different. Being low glucose makes you feel different. These are very non-specific things. It's the same with inflammation. So inflammation, or some of the processes Jenny's talking about, like cytokines or whatever it may be, can throw things out of balance. And if if a particular person's constitutional makeup and brain has a tendency to be anxious or a tendency to be depressed or something, that can be thrown out of balance in a non-specific way. And as that gets worse, that can lead to delirium and confusion and so forth. These are non-specific effects where just the milieu's out of balance and the brain can't function properly because the environment that it requires has been thrown off. So that would be a non-specific way that inflammation can affect the brain. The specific way is if something in the immune system, so the immune system's job, one of its jobs, is to go in and get rid of things that shouldn't be there, right? Viruses, bacteria, whatever. So if the mechanisms that are designed to get rid of things that shouldn't be there get mistargeted and start damaging or affecting specific parts of the brain. So, for example, in these disorders, PANS and PANDAS, we think that there's inflammation in the brain, not everywhere, but in certain specific places, especially the basal ganglia, and maybe even specific cells in the basal ganglia. So it's a very specific mistargeting of the immune system. Well, once you start screwing up or imbalancing or perturbing particular cells and circuits, those cells and circuits are what processes information in the brain, and that can tilt all of that information to a different mode of processing. And that can lead to anxiety or it can lead to OCD. So I think it's useful to think about, like, before getting down into this cell, that cell, and cytokines. Those are critically important things to understand in order to get a full picture and in order to design therapeutics. But broadly, you can just sort of throw things out of balance, or you can accidentally, you can specifically target aspects of the brain that cause it to function in a specifically abnormal way. And that's what we think is going on in PANS and PANDAS.
I have a question that's really interesting to kind of think about. What, like, well-powered longitudinal studies do we have that show that process directly leads to the cause, the onset of OCD, as opposed to just kind of being correlated with OCD symptoms?
Yeah, that's a real easy question. None.
Yeah.
You're making some really strong claims, but what you're saying is we don't quite have the data to back that up yet.
Well, I didn't claim anything actually about what actually happens, and that is getting into the weeds, and we have to talk about. I claimed what could happen, like the ways to think about these processes, so that one can frame questions in a way that can be answered. But yeah, a lot of the stuff. I mean, Jenny said at the beginning that she works in a controversial field. This is why the field is controversial. Everyone's got an immune system. Everyone's got inflammation. Infection is common, right? OCD is relatively common. Anxiety and depression are super common. So when common things happen together with common things, it's very hard to say with confidence that there's a direct relationship between them as opposed to a coincidental one. There are multiple reasons to think there is a non-coincidental relationship between dysregulated immune system and some cases of OCD and some other psychiatric conditions. But it remains really difficult for precisely the reasons you're pointing out. Yeah, what we'd like to do is follow 1 million kids for 10 years, sampling all of their functions every 6 months, so that we can see what precedes what and what leads to what, and then do very specific causal manipulations to show that that's what we need. We don't have it.
But I think the data is building that there are causal relationships, right? So Dr. Pittenger's work, what I loved about it is that he actually showed that those antibodies modulated the metabolism of those cholinergic interneurons and the electrical firing of them. Am I quoting your work correctly?
Yeah, I mean, Kyle, I don't know how far into those weeds you want to get, but I can give a brief summary of that work if that would be of interest.
I do want to get into those weeds, and particularly about like cholinergic interneurons and whatnot. But before we get into those weeds, I want to take a step back, just for the sake of our broader understanding of things. Like, what are kind of the hypotheses about how inflammation could lead to something like OCD? Like, what are kind of the thoughts that would spur the questions that you, Chris, you, Jenny, you, Donatella, are asking, and then John may, wonder.
And to that point, like, why OCD and why not like another problem with anxiety or another psychiatric disorder? Why OCD about religion versus OCD about symmetry or contamination? What do we know about that?
Yeah, those are really interesting questions.
Yeah, let's say, I think already Christoph underlined an important point, that you must have an individual vulnerability towards developing one or another disorder, because the main pathways more or less are the same in everybody, but there has been a negative consequences of the same inflammatory agent or triggers. And so you go in one way or another way. So individual fragility, type of stressor, and then the point is that what came first? We don't know. And why somebody develops one type of OCD, we don't know, at least now, until now. So it's better to be very cautious. And I think, according to me, it's very impossible to answer this question. Too many factors.
But also to answer your question about why OCD, and it's not just OCD, we're just talking about OCD today, right? Like, if you look at rheumatologic diseases, there's a very high rate of other psychiatric disorders in rheumatologic diseases, higher than the baseline population. So I think, inflammation is playing a role we think, in potentially many psychiatric conditions, not just OCD.
So what determines whether the person, whether that leads to OCD or leads to social phobia or depression? Or
now, you think Christoph already said that for different reasons you develop OCD, because there are specific circuits for OCD that are prone to be disrupted, let's say. In other individuals, there are other brain circuits and so on. And that's probably what created the differences: genetic risk, load, individual development, type of childhood, and so on. So another important aspect, promoting onset of psychopathology, is a very difficult childhood. And in Yale, there is a lot of studies in this field. So a prerequisite to be healthy from the psychopathological point of view, to have a healthy childhood with a healthy environment, not only from the biological point of view, but from the social point of view. And so I think the most fascinating data deriving from study immune system and interaction with the environment is the broader concept of the environment. To be healthy, we need a good family, we need good parents, we need good food, we need good school. And so, I mean, the frame is not a frame. The picture is very complicated and it's fascinating. And
Mhm.
even us probably will provide during our life just a very small contribution to this complex picture. That is fascinating. At least I would like to live 200 years at least to see the next development.
And I agree with Donatella, but I also want to push back a little bit, because I've also seen hundreds of really, really healthy kids whose parents did everything they could to make sure they had a healthy diet, a healthy environment, lots and lots of love. And they're so unfortunate that they get lupus and
Yes,
they
that's the
become
point.
psychotic, right? Or they get some other inflammatory condition that wasn't the environment's fault per se, may have been infections, may have been immunogenetics. So, just to make us all forgive ourselves,
Yeah.
that as hard as we work to make our environment great for our children and our families, it's
Yes, that's
unfortunate things happen. And I also wanted to make
factors that can contribute to
Mhm.
a problem like OCD in any of the
And
mental health disorders.
yeah.
so that it's multifactorial, but to kind of drill in on OCD and this potential factor that is inflammation. Donatella, you mentioned that there are circuits in OCD that we suspect may be affected. I was wondering if you guys could just again help like set the scene a little bit. Like what are these circuits that may be affected?
No, but we know, but I mean, we know now, perhaps today, tomorrow, we don't know. So, Voltaire said that in medicine, let's say in science, certainties are dangerous and
Mhm.
doubt is good. So I would say what we do know until now. When I was a young doctor in the very beginning, I was very rigid, and I thought depression, low serotonin, and so on and so on. Now I'm totally different.
Hmm.
So I thought that I could discover the biology of one psychiatric disorder. Now I think it's very difficult. Anyway, I will answer your question. We know that in OCD there is a disruption, an alteration of the orbitofrontal basal ganglia circuit, and there are several data supporting this notion. And also, when you recover, this circuit return to normal level. It is hyperactive, it works too much. So in both serotonergic drugs increasing the level of serotonin in the brain, and even CBT, cognitive behavioral therapy, can restore the normal functioning of the circuit in parallel with the benefits of the drugs and of the therapy. That's what we know for now. But what is important now, we are testing new drugs, we're targeting other systems. So there is a lot of innovation or possible innovation in this field in terms of even in targeting the immune system is another field of it is a promising field for novel treatment strategies. Are you happy, Kyle?
I mean,
I
wish
orbitofrontal basal ganglia circuit.
I always wish things would be simpler than they actually are. But okay, so there are, as of right now, some brain regions that we associate with OCD. What what is the evidence that inflammation may impact these pathways, these circuits, what have you, that may lead to OCD, as you know, as I'm going to state, and then John can push
We
back.
don't know. No, I mean, the evidence would be that propose alternative strategies such as antibiotics or anti-inflammatory drugs that seem effective in OCD might impact the circuit.
Yeah.
Because we have evidence for the drugs, we have evidence for the CBT, so we don't have for the novel treatment. Probably we will have. So let's go ahead.
So Kyle, there's a couple pieces of evidence, of studies to do the kind, to answer that question. Why do we think this topic's worth talking about at all? Why do we think that inflammation is associated with OCD? None of them are perfect. So going back to John's question, we don't have a long longitudinal study that really isolates the causal factors. But we do have a bunch of different ways of looking at it. So one is when you have sudden onset of OCD at the same time as you have infection and disruption of the immune system and inflammatory processes. And when you see those things go together enough times, you start to say, well, there might be a connection here. And that was the observation that first led to the idea that some pediatric OCD may be neuroinflammatory in nature, but Susuito's group back in the 1990s. And then you have to ask, well, is it a coincidence, and what's the causal relationship? So, that's a rabbit hole that we can go down into if you want. But that association, that an inflammatory process coincides with and seems to contribute to new onset of OCD. And you can see that in PANS and PANDAS, but you can also see that in, lupus leads to psychiatric symptoms, and autoantibodies against the NMDA receptor leads to psychiatric symptoms. And so there are many examples of a new inflammatory process leads to is coincident with new onset of psychiatric symptoms. And then in some cases is coincident with brain imaging data that suggests that there's brain inflammation going on. So you see those things go together, you start to think there's probably a connection there. So that's one type of evidence. A second type of evidence is if you look at people with OCD, and this is even more true with Tourette syndrome, but it's true in both OCD and Tourette's. Just look at everyone with OCD, everyone with Tourette's. Monitor their immune system. Look at cytokine levels, look at various levels of immune mediators. You see differences between people with OCD and Tourette's and the general population on average. Now, does that mean that every single person with OCD has immune dysregulation? No, it doesn't. But it's an additional piece of information suggesting that there might be an association there. A third type of association, which Donatella was just commenting on, is treatment response. Some people respond to immune modulatory treatment by getting sometimes a lot better. Now, it's a minority. But again, that kind of association is the kind of evidence, and you can get into the details, but it's the kind of evidence that makes us think something is going on. And then the final type of evidence, I would say, is mechanistic studies. When we find that neuroinflammatory processes can affect the brain circuits that we know are disrupted in OCD or any other condition, and they affect them in a way that is consistent with the way they're affected in OCD, that lends further plausibility to the idea that this is a causal pathway that could plausibly lead to OCD. Now, each of those categories of evidence is imperfect. None of them gives a compelling, and each of them can be, this is true, as Donatella was saying, in most of science. We have sort of convergent, imperfect evidence that leads us to have a general worldview, which will change over time. But these are the categories of evidence which right now convince me, having come into this field as an outsider. I'm not a neuroinflammatory person by constitution or training, but has led me to be quite convinced that in some cases, these processes can contribute to OCD and are worth understanding. But no single study proves that beyond a doubt.
If I can add some data of my group, is that in a large sample of OCD patients, we saw that about 250 patients, about 85 had the sign of a previous mononucleosis infection, Epstein-Barr, and other viral and bacterial infections. But I just mentioned mononucleosis because there was a relationship with the severity of the disorder. The patient with previous Epstein-Barr, and most of them didn't know that they had suffered from this infection were more severe than the patients without it. So this also is a good indication that there might be a relationship, even while considering that there is a recent study, long follow-up studies with patients with multiple sclerosis showing a similar strong association. And I mean, our patients had different infection, but only the patient with previous mononucleosis had this positive relation with the severity of the disorder. So I would go to investigating more thoroughly the relationship with this silent virus. They are not so silent as we wrote in the paper. And this should be more truly investigated in the future. And also we saw, as clinicians, a sort of exacerbation, a worsening of OCD in patients who had the COVID infection. And in some young girl, we saw both. We saw that COVID also was able to exacerbate a previous mononucleosis infection. And 5 girls, we are just writing this paper, were a very severe COVID and a very severe mononucleosis on the same time, after some years from the previous infection. So we should study more deeply these viruses.
And I wanted to also give a historical example of Sydenham's chorea, which is highly linked to perseverative behaviors in OCD. Was very controversial, even though we knew about acute rheumatic fever, which is the umbrella disorder, and we knew that strep triggered acute rheumatic fever. It was very controversial to think of strep triggering Sydenham's chorea. And it wasn't till strep was, eliminated, at least the bad strains from our environment, we saw the rates of acute rheumatic fever and Sydenham's chorea plummeting together. And then people thought, oh, they could be linked. So again, to go to Chris Pittinger's, sort of one of the lines of evidence is epidemiology and seeing these rates of the things going together.
So just adding something, we have most, our patients are almost adult, but we also investigated the previous streptococcal infection. At least we have a lot in these last winter times, probably even in US. And so we were interested in streptococcus, and we see that about 1/4 of patients with OCD had a previous streptococcal infection, and most of them didn't know that. And so that's another point that we always discuss with physicians, to prescribe or not prescribe antibiotics in these patients when they have a high titer, streptococcal titer, ASO titer. What do you suggest, Jenny?
That's hard. Right, because as you both pointed out, there's these infections are very common, so we don't know in every individual whether strep is a factor. We never know. And what they did with Sydenham's chorea is because of the epidemiologic link, they decided to treat every new onset patient with chorea with strep, and same with acute rheumatic fever, right? So even though it's an epidemiologic link, we do treat every case with penicillin to sort of get, but it's not just treating the patient, it's getting it out of the household. So, which means you're going to treat, just like we take appendix out of patients that don't need their appendix out, right? 1/3 of the time when we remove an appendix, it was fine. We would, if using this approach, over-treat strep. Because we don't know. But that's the risk we take.
So it sounds like there's, different categories of evidence, and as Donatella's made clear, like there's, epidemiological evidence that seems, I don't want to say strong because I don't know all of it, but like it's certainly there. And then Chris, you mentioned kind of more mechanistic evidence. How strong is the evidence that there's some sort of mechanistic connection between infections, inflammation, and the development of a psychiatric disorder, or the onset rather.
Yeah, I'd say that where we are right now is that from a mechanistic point of view, is we're getting a better understanding of mechanisms that make sense, like precise, specific mechanisms that make sense. But we don't yet have the evidence that those mechanisms are actually what's happening. Okay, so a first generation of a mechanism that would make sense is we know that in certain infections or inflammatory conditions, you can get inflammation of the basal ganglia. We can see that in animal models. You can see that in neuroimaging in certain cases. And we know that inflamed basal ganglia process information differently. They don't work the way they're supposed to. And we know that disruption of basal ganglia is involved in OCD and Tourette's. So there's a sort of high level, not very specific mechanistic progression that each step of it works. Okay. In some of our recent work, we've got a much more specific example. So theory, kids with pandas have antibodies which should do stuff to the brain. If the theory, now pandas is pediatric autoimmune neuropsychiatric disorder associated with streptococcus. It's like the paradigmatic example of an autoimmune triggered form of OCD, probably familiar to most people on this call. But so if the theory is correct, that strep leads to an autoimmune response, which leads to antibodies, which do stuff to the brain, which affect brain function, which lead to symptoms. If that theory is correct, we ought to be able to find those antibodies, right? And people have looked for a long time. There've been some reports. It's kind of unclear. What we figured out a while back is that if we take serum, if we take the blood from kids with pandas, and this is pandas, clinically it looks like pandas. This is not any kind of magic. We're 100% sure diagnosis, but kids who look like pandas clinically, we take the antibodies in their blood and we see what they stick to in the brain. It turns out they stick to this very specific type of cell that was mentioned earlier, the cholinergic interneurons, my current favorite cell in the brain. I know we all have our favorite cell in the brain. This is my favorite cell in the brain. So they stick to the cholinergic cells in the brain, in the basal ganglia. They affect their function, so they cause them to not fire as well. And that turns out to be really, really an interesting finding, because we already know that if I mess up those cells in an animal, I get an anxious, twitchy mouse. So we already know that disrupting those cells can lead to, not OCD, but anxious, twitchy mice. So, and we already know that some people with bad Tourette syndrome have a deficit, a problem in these cells. So we already know that these cells are important, that they're involved in processes that are at least in the same universe as the symptoms of OCD and Tourette's, though I'd never say a mouse has OCD, so I can't say that, but they're at least in the same universe. And so this again gives us I gave you sort of a very general inflammation, basal ganglia behavior story. This is a very specific story. Inflammation, antibodies against this particular type of cell, disrupts them. Disrupting that cell leads to behaviors that are in the universe of OCD. So that's a very specific mechanistic story. And having that kind of story makes it easier to think about how this could be happening in humans at a specific mechanistic level of the type that modern medicine and the development of specific interventions requires. We don't have proof that story I just told you is what's happening in kids with pandas.
There's just
we
a
have
lot
proof
of
that it can happen. And it does happen in mice when we take the antibodies from the kids with pandas. We don't know that it does happen in those kids with pandas. That's work that's ongoing.
And then, subsequently, screwing with those cholinergic interneurons leads to the development of what we would call OCD,
I wouldn't call it. I stick with anxious, twitchy mice, but
okay.
It's in the same universe.
It's in the same universe. Yeah.
I want to just kind of push back on that a little bit. How is anxious, twitchy mice in this universe as a human being with OCD?
Well, this is why there are people in the field who will say that they have a mouse model of OCD, that their mouse has OCD. I think that's silly. I think that OCD requires a complexity of consciousness and self-reflection and volition and a verbal report of all of those things that we can never recapitulate in a mouse. And even if a mouse could have those things, we would never be able to tell with confidence that was what was going on. So I do not think that a mouse has OCD, and anyone who says it does, I think is eliding a lot of conceptual complexity. At the same time, we share 99% of our genes and 95% or so of our DNA sequence with the mouse. We have our brains have all of the same all of the same portions the same general anatomical regions that are connected in the same general ways. Really important differences that have come up over 100 million years of evolution, but the same general patterns. It would be bizarre if, since we know that OCD has a genetic component, we know that it has a brain-based component, it would be bizarre if there were no analog to any of those processes in the mouse. So on the one hand, no, the mouse will never have OCD. On the other hand, it would be bizarre if the mouse had nothing to teach us about OCD. And so then it becomes a complicated conceptual question. How do we know, what is it that the mouse has to teach us about OCD?
Yeah.
The way I approach this is, if I have a gene that I know is associated with OCD, there's no ambiguity about what that gene does in a human and a mouse, and I can study that in a mouse, and that's interesting. If I have a brain circuit where the mouse has the same fundamental brain circuit in the mouse, now, as the human. Now, it's not exactly the same. The human brain is much bigger. The circuits are more complicated. But the fundamental organization of the brain circuit is the same. Well, then learning how disruption of that brain circuit affects the broader system at the level both of neural circuit function and at the level of behavior, that's fundamentally interesting. I do think that it will not be the case that every single thing we learn from a mouse will turn out to be relevant to OCD. Absolutely not. But it would be bizarre if none of it was relevant to OCD. And so we need to work in that space and accept that there, as in every other aspect of science, will always be some degree of uncertainty as to where the twisting road of knowledge will lead us at the end of the day when we have more complete knowledge than we have today. But the fact that it's a twisting road and there will be some dead ends and some red herrings doesn't mean it's not worth walking.
I can add,
thanks for letting me play.
I would like to add something, that the most difficult lesson I had to do this year was on animal model
Oh,
in northern Italy. So because
Donatella, you cut out there for a moment. Could you repeat what you're saying?
I wanted to say that the most difficult lesson of this year was a lesson on animal models of OCD. It was because the problem at the end, what we can conclude is that the problem are not the mice, as Christoph said, with which we share a lot of genes, most of our genes. The problem is human. We are unable to create an animal model of OCD. What do you think, Christoph? It's our
fault. Well, I just think that there are aspects of OCD that, as I said, it's unlikely the mouse can get them. Mice don't have, their frontal cortex isn't as well developed. Their cognitive abilities aren't as well developed. It's unlikely that the mouse can get the symptoms of OCD. And if it did, there's no way we could know because they can't tell us about their internal experience, right? So I think that asking a mouse to model OCD, I think, is a fool's errand. More interesting, could you ask a monkey to model OCD? That's maybe a more subtle and interesting question, not something I've done any work on. But asking a mouse to model OCD, I just think is a fool's errand. But again, to just emphasize the other side, thinking that a mouse has nothing to teach us about the relevant processes, I also think is just wrong.
So, I suppose we've to kind of try to summarize, the immune system's very complicated. Immune system's very complicated. Now I'm going to go very general. Inflammation is very complicated. There's epidemiological evidence that there's an association between inflammation and OCD. There's some interesting mechanistic stories. But as John would be remiss if I didn't leave in, causally, there's a lot to be wanted. So I suppose, I'm sitting here as someone with OCD. What do I leave this stream thinking? There was a question in the chat a few minutes ago. Amy Alexson said someone I know had strep as a kid, which led to rheumatic fever and Sydenham's chorea. Years later, he developed a mild case of hoarding. Coincidence? Who knows? And that's kind of where my brain is at. There's a lot of people who have these infections, viruses, what have you, and then a lot of people with OCD. How do I conceive of everything we've spoken about if I'm one of those people?
Well, and let me just throw one more kind of thing into the mix. We know that neuroinflammation can be inflammation is a downstream effect of chronic stress, anxiety. We know that the mind affects the body. And so, we're looking at things, we want to think about what's causing OCD, right? Because that's really sexy and fascinating. But it's also possible that having OCD leads to the very inflammation that we're observing. If we don't have causal data.
Yeah. It's a really important point, John, and I'm glad you made it. Is that this is a bidirectional interaction between the inflammatory, and we've been remiss in talking as if this were mostly a unidirectional, and it's not. I mean, going to your question, Kyle, here's how I would think about it. We know that OCD arises from a combination of our constitutional makeup, genetics, early environment, whatever that may be, our environment, infection, inflammation, whatever that may be, and our experiences. Right? Those are we know that OCD arises from a combination of those things. And we know that all of them matter, like how much they matter, what percentage, that depends on how you ask the question. But they all three matter, okay? So inflammation or anything that affects the brain, I mean, so two people have the same set of experiences, one of them may develop OCD or depression or PTSD or whatever other psychopathology, and another person doesn't. Why? It's because the same experience, the same interactions with the social and physical world is interacting with a different brain that has different vulnerabilities, right? So inflammation you can think of as affecting the vulnerabilities of the brain, whether that be in a generic way by just saying everything's a little off because of inflammatory mediators, or in a very specific way, like this particular kind of cell isn't doing its job properly and that changes information processing. But that's going to change the vulnerabilities or susceptibilities of the brain. And the details are unimaginably complex, but the general idea that if you had different genes, well, things would be wired up a little differently. You'd have different susceptibilities. If you have an inflammation, things aren't functioning quite the same. You're going to have different susceptibilities. And that may interact with the other aspects of development in order to give one person OCD and another person not. So I would think of inflammation as one of the ingredients alongside genetics and nutrition and exercise and early life environment and dust mites and Lord knows what else. One of the things that causes some of our brains to be different from others, which causes some of our reactions to our experiences and over time to be different than others. One of the pieces. The question is, are there cases where it's a huge piece and such a big piece that it deserves a central place in our explanation of pathophysiology and a target of treatment? That's where the controversy is. I don't think there's any controversy about anything that I just said, or at least I don't think there should be. All of these things interact, they set up susceptibilities, and that leads us to have different experiences and different reactions to our experiences. I don't think any of that's remotely complicated. The question about inflammation is, are there cases where inflammation is a central player as opposed to one in the choir? That's the question. So in the case I had Sydenham's chorea, now I have a case of hoarding. That I would translate that into, are there lasting effects of the Sydenham's chorea and the processes that underlay it in my brain that increased my odds of developing hoarding later in my life, in conjunction with lots of other factors, biological and psychological and social? I don't know the answer to that question, but that's how I would reformulate the question in terms of these constructs that I'm trying to lay out.
Jenny, you were saying a lot. I was wondering, what do you?
No, I agree. I mean, I thought that Sydenham's chorea example was great, but I think, and I completely agree with Dr. Pinger. But the way we think of Sydenham's chorea in the rheumatology world is that you're always, if you have the diagnosis of acute rheumatic fever and Sydenham's chorea, you are always vulnerable to inflammation from strep infections. And the standard of care is that, people remain on penicillin, and when they have an uptick in neuropsychiatric symptoms or joint pain, that themselves and the family members are screened for strep, and the baseline penicillin prophylaxis is increased. So in addition to that person paying attention to all of the environmental factors, anxiety, stress contributing to the hoarding, they should also be, monitoring themselves for arthritis flares and for a strep in the home. That would be the standard of care.
For that particular
case. And if it was a lupus case of someone that had childhood lupus that went into remission, if they had an uptick in their psychiatric symptoms, they started hearing voices, that they should go back and get reevaluated for, evidence of inflammation, lupus specific inflammation, in addition to thinking about the other stressors that could lead to,
that could lead to
a
an
mental
uptick
health
in
situation.
psychosis.
So it should always be it is multifactorial. So the evaluation and management should always be multidisciplinary in those cases that have been proven.
I want to be respectful of time. Donatella, do you have kind of like parting words that you may want to throw in there before we have to end the stream?
No, I think I agree with both my coworkers. So I totally agree.
Yeah, that this ought to be multifactorial in nature,
Yes.
considering how this
Well,
all.
as I said before, so I don't want to repeat any longer. I think it was clear from week 3 that this is a complex disorder that is obviously due to different factors.
Mm-hmm.
That should be studied and deepened. And inflammation is probably the final common pathway of different triggers.
Mm-hmm. Yeah, I agree with that. Yeah.
Well, we said at the beginning of the stream that it's important to come back to things after you've gained some life experience. And after I do my immunology block here at medical school, I'll come back to the stream and hopefully understand 75% of it, because I only understood about 25% this time. But thank you all for joining. I really appreciate the
Thanks a lot.
discussion. Yeah, and for everyone who's listening and thought, wow, that's really cool, please go to iscdf.org/donate-research to help fund research like this. All right, everyone.
Great. Thank you.
Bye.
Bye.
Thank you. Take care, everyone.
Bye.
Bye.